So definitely PET scan has a significant role in malignancies, both pre and post, I would say. Pre, it will help us target the node, and post, definitely if you have a malignancy resectable, we would still do it. So for want of time, I think we will quickly start the third case. I would request Kedar, Val, everybody to call them. So the third case is a case who has been referred for diagnostic EBUS. He has a large paratracheal mass. So we have already shown TBNA, so we won't be showing it again. The intent of this case is to show the newer techniques in the EBUS, in the new EUME3 processor. So Pradeep, can you hear me? Audio from there. So now Pradeep will be showing So he will be showing some of the new features in the EBUS processors. So one of which is elastography. Pradeep, can you quickly show the node and the
So sir, as we can see, we saw a huge endobronchial mass from the right main bronchus, and also external compression compressing the trachea, the carina. So we are at the carina now. The patient also has a large right paratracheal node. I will just localize that node for you. We can see the SVC underneath and the right paratracheal or 4R node. So this we are initially showing you in the normal B mode. The new EUME3 processor has various features which helping in enhancing the node structure. So first of which we will be showing the structure enhancement. So we will just be shifting out to the structure enhancement mode.
So in addition to the gain and contrast, so gain and contrast have been discussed earlier. So this has new features. One is called the SE, surface enhancement. Okay, can you show it? So if you can see here on the left side of the screen, you have G, C, surface enhance and LER. So this is the two extra features which are there now in the new processor.
So now
go from less to more.
This is 8 now. Now we are going to less.
So you can see the periphery of the node. Correct, Pradeep?
Yes, sir.
So it is not very clear. If you increase the structure enhancement, the structures will become more well delineated.
More well defined, yes.
Yeah. So you can see from 1 to 8 if you go, the rim becomes well more clear. Yeah. But actually an ill-defined node will become well defined, I would say.
So and then there are two modes, sir, in this.
LER.
LER will show, sir. First we will show the THEP and THER modes.
Okay. So the other thing which you have to understand is conventionally we use what we call as the B mode. B mode is what is used, which Dr. Varun also was talking about. But in B mode also you will have some. So to decrease the artifacts, you have what we call as the tissue
harmonic echo.
THE.
Yes.
So THE mode has been there in the ME2 also. So now we will show B mode and the THE mode.
Yes. So this is the B mode. Now we will shift to the THEP. So P stands for penetration. So generally if you have a large node which you are not able to, the distal part if you are not able to see with a normal EBUS, then THEP will increase the penetration, and even the distal part of the node will appear clearly.
Okay. Then again switch between these two just for the sake of the audience. See, all of these are basically to make the node more clear, more defined, more delineated.
So when THEP is put, you can see that in the lower half of the screen the echoes are increasing. In case it was fully occupied by a node, the distal part would have become more clearer in using THEP.
Okay.
Now this is back to the B mode. Now we will use THER. So THER, R stands for resolution. So basically this is used for a small node. In case you have a small ill-defined node, in case on using THER mode, the node will become more clear and more well defined.
And on the top you can see there is the green letters. Now what mode is there? B, THEP and THER. Quickly we will do the elastography also.
Yeah. So now we will put on the normal elastography first, sir. This processor has intelligent elastography and normal elastography. We will first be showing the normal elastography. So no, put the area of interest totally in the lymph node.
So when you put elastography, you have to select the
reduce
node.
The area of interest.
Yeah, so that's called the area of interest.
Upwards. Yeah. So now you will see greenish, blue, red, yellow shadows coming up on the screen. So basically you are seeing a graph at the lower right corner.
Pratik, we can't see the colors here. I think you should flex more on the elastography. Elastography is also highly dependent on the
Now.
Yeah.
So now on the bottom right, what graph you are seeing? When the graph is completely within the upper and the lower, that is +6 to -6, that is where you freeze your image to get a elastography image. So here you can see the node is predominantly blue and there are some areas of green. So elastography basically tells us about the stiffness of the node, blue being the hardest and red being the softer part. So here we can see that the node is a very hard node.
So basically we said that harder the node, more is the likelihood that it will be
Malignant.
abnormal. It is not a normal reactive node, it is likely to be infiltrated. So this case was anyway high probability for malignancy. You had an infiltration with the right ventricle also. It's a huge, predominantly blue node. So it is high chance of it being malignant. Quickly can you show the eye elastography?
So elastography we will just unfreeze and put the eye elastography. So we have switched over to the eye elastography. Eye elastography is more useful when the pulsations are less. So here you are seeing now that you are seeing more amount of color elastography images is more clearer now, and we'll freeze the eye elastography now. So there's slight difference in image. The eye elastography is showing a half blue, half green node with about few areas of red and yellow areas. So not completely a very hard node.
Pratik, can I interrupt? I think it was more to increase the sensitivity of the elastography. I think the location where you have kept has slightly changed, that's why it is looking more red. So if you put the normal elastography, if you can see the number of times you saw the elastography image was very less because the pulsations were not transmitted to that part of the node very well. If you put an eye elastography, then it is seen more uniformly. So that is the advantage of increasing elastography. So but again there is not much data on eye elastography, I would say. But then for nodes where there is weaker pulsations, it will give a better image. Correct?
Yes.
Anything else you want to say? Semi-quantitative methods?
So basically we have what we call a strain ratio and strain histogram. So strain ratio, basically we select two areas A and B. The area A is usually the hardest part. You select a hard area within the node. Increase it.
So now the first way to look at stiffness is the qualitative. You just look at the color. Predominantly blue, predominantly non-blue, and so on.
Increase the size.
What he's trying to show is the semi-quantitative way. So you have an objective
increase the size
way to
more.
assess.
More.
So he's selecting an area within the node which is
up little up.
which is more blue, which is the hardest node, and he will compare it with the periphery of the lymph node.
And now we have to select another area slightly adjacent to the lymph node. What is this?
Like with other imaging appearance, this is also non-specific and non.
Exactly. So this is just for that it is there, and all
Down,
these are
down,
can be done.
bring it down.
More often
Down.
used for pancreatic lesions,
Yeah.
I would say.
Little bit up.
In EBUS,
Little bit
there
in
is data
contact.
for elastography that
Little
it
bit
will
in
increase
contact.
the likelihood, but it can never replace TBNA.
Okay.
So
Enough.
TBNA is the gold standard.
Okay.
So it's not just elastography, there is also a lot of data which was coming out on grayscale analysis as well. What is in my wish list is not B mode, C mode, but I would like to see something called as a D mode, the diagnosis mode. So if all of us can put one small circle and say D mode and give us a diagnosis, we don't have to do anything.
I think
that solves the problem. Yeah, he's raising his hand out there.
Thumbs up. So we want a D mode next time in the EME4 processor.
Tell them the pathologists here are annoyed.
So Pratik, are you able to do it?
Yes, sir. So basically we have done the strain ratio here.
Can you explain for people like me who don't know it?
So here you can see at the bottom left area, you can see a B by A ratio. Here in this case it is 3.5. The larger circle just cutting through it.
So here you can see A, B and B by A. In the
B by A.
Bottom corner.
Yes. So A is within the tissue, B is outside the normal tissue. So basically here higher the ratio, the stiffer the node and more chances of it being malignant. So generally they say cutoff of 7 is what has a sensitivity about 88% for diagnosing malignant nodes.
But anyway, see here you have not marked the B correctly. B is not in the elastographic image. So nevertheless, so this is one of the modes, one of the semi-quantitative ways to assess. Anything else you want to show, Pradeep? Or shall we move on to the last talk?
If we do a TBNA puncture, we can show the LER, sir. LER, the low echo reduction.
If you can do it in 1 minute, yes.
Yeah, sure.
So Nagarjun, just from an academic standpoint, companies are coming out with all sorts of imaging. Olympus comes up with NBI. Pentax has their own blue light imaging, or I think some B light. Now we're talking about elastography, TEF mode. But I think finally, with all these modes, from an academic standpoint, and not to criticize the technology, are companies just pumping in more and more technology, which may or may not make a difference, because at the end of the day, none of these technologies have the so-called D mode in this, and finally it's up to you and me to establish it.
It is a very valid point that will it make a difference in diagnosis? Unlike the previous techniques which we have shown, at least have a diagnostic implication. Getting a biopsy will increase the yield over an aspiration. Doing an EUS may increase the diagnostic yield in staging EBUS and help us. But all of these endosomal advances, I would say, are more extrapolated from the gastro. I would say all of these have come from gastro. Elastography also is not EBUS to begin with. It is for the pancreatic lesions and other lesions where they have a role. Apparently they have a role. But in EBUS they have extrapolated it, but it is not translated to clinical benefit.
The last paper on narrowband imaging, to the best of my knowledge, was probably in 2007 or something like that.
So
and I have not seen a paper on elastography in pulmonary medicine after the first paper by Takahiro Izumo from the National Cancer Center.
Elastography, there are a lot of papers, there are 2 meta-analyses also. So there is data, but there is no data to say that it can replace a biopsy or aspiration in the near future. Only thing, whatever review articles are there, is that if you are not getting a diagnosis, you do an elastography, find a more blue part and put a needle in that part. So that is probably the only thing which the review articles say. But at the same time, it is important for us to at least know what is happening. So if you don't know what is happening, then it is not good.
These are technologies which are still finding an indication.
Yes. So EBUS elastography will not be a routine for all of us. It is there for us to know that it is there, and if you want to use, there is nothing against them using the elastography.
So I actually wanted to highlight this point.
So can you quickly show the LER before we
So basically now we are on LER 3, sir.
So this is another thing, low echo reduction.
Yes, sir. So we can see that there is a lot of noise around the needle. As we keep increasing the LER, please increase it, we will see that the needle becomes more sharper and clearer, and the noise is reduced around the needle.
So basically it makes the needle more clearer. Why again they say that if the tip is not clear, it is blurred, you might sometimes go beyond the node and you don't know where the tip of the node is. So while if we see the tip clearly, the safety of the procedure increases. That is the only benefit of LER. So it makes the peri-needle area more clear. That's all. So I think Pratik, with this we will stop.
That's it. Yes.
Yeah. Thank you so much. So this is just for us to understand the new advances in the EUMA3 scope, EUMA processor, which are there for us. It is not that we will ask everyone to do it, but it is important for us to know. And with this we will stop the projection, and then we will ask Dr. Pawan to come and present the last talk, after which we will have one more small case, that is staging EBUS.